Okay, good morning, everybody. So to get started here, I'd like to introduce my course director, Dr. Michael Johnson from St. Joe's Health. And will give his introduction, and then I'll say a few words, and then we will begin the meeting. Mike?
Good morning. Thanks for coming. Thanks for taking time out of your weekend to be here. We have another great program to offer you to showcase some of the local talent here in the area. We're very excited to partner with Northern California Medical Associates. It's the fourth year, I believe, that we've done this together, and NCMA's done this meeting for a long time. Anybody here for the first time? Oh, there's a couple people. Okay, great. Well, welcome. Welcome. So my role, I'm the Vice President for the St. Joseph Health Medical Group, and I wanted to thank Dr. Bierbaum and Dr. Dunlap for putting this all together. They put a lot of time and effort into this, and I'm really looking forward to listening to the first speaker. So, Dr. Dunlap?
Thank you, Mike. So on behalf of Northern California Medical Associates and St. Joseph's Health, welcome. It's great to see everybody, a lot of old faces and some new ones, and we always enjoy putting this meeting on. It's good for me because it makes me kind of dig into the archives of what I think is important and talk with people and try to put together something that I feel is stimulating, interesting, and educational. At least this year we have inclement weather, so it doesn't feel so bad being inside all day Saturday. I hope everyone is recovering from the October fires that devastated our communities, and especially our physician community. But it was inspiring to see how our physician community stepped up during that time, and our hospitals stepped up to help their fellow physicians, their patients, and their community. A lot of people sacrificed a lot, and it was really, truly inspiring. So I hope those of you that are affected are recovering. Medicine continues to evolve very rapidly, and to help meet this, it helps us care for our patients, and to help meet our educational needs, we continue to delve into the science and art that is medicine. And we hope that this meeting that we've put together today it does that. It becomes a little bit more eclectic every year. When it started out, it was just a cardiology update for primary care doctors, and now it's evolved into something much more, and I think really much more interesting. We've put together, I think, a great meeting combining the talents of St. Joseph's Health and NCMA. Before we begin, I'd like to make some some thank yous. Please thank our sponsors, which includes Medtronic Cardiac Rhythm and Heart Failure Management, Medtronic Coronary and Medtronic Heart Valve Therapies, Boston Scientific Cardiac Rhythm Management, Abbott Cardiac Rhythm Management and Electrophysiology, Actelion, Bristol Myers Squibb, LabCorp, Quest, Regeneron, Sanofi, and Zoll LifeVest. I'd also like to extend thanks once again to JP Montemayor, who's our audiovisual nerd, who makes this meeting happen in a way that we can all enjoy the visual and sound aspects of it, and he does this every year. JP lost all of his AV equipment in the October fires, but is slowly building back up his stock. So please visit the exhibits when you're able. There's a break between at 10:30 and again at 2:40. Lunch is at 12:15 to 1:15, and again this year because of the weather we'll be eating inside at the ballroom that's just to the south of us here. Dr. Nakai will be having his breakout session during lunch, and he also has a talk later in the program. The restrooms are through the doors and that way, if so needed. And make sure that you take a look at your evaluation packet and complete those for your CME credits. Additionally, the meeting will be recorded and will be on YouTube in about a week. So if you missed something or you particularly enjoyed a talk, then you can go back and look at the whole thing on YouTube. Also, Morgan from St. Joe's will be sending the slides to those of you that have supplied an email address, and if you didn't do that, then you can give him your email address or to Deborah Spasti, and they will make sure that you get a set of the slides by email. So, our keynote speaker today is Dr. Jack Boyd, and robotic surgery is becoming more a part of standard practice as things evolve. And we heard talks last year about this, and there was the Da Vinci machine here that some people got to play with, and so we've been introduced to this technology, and it's now being applied in OBGYN and other aspects of medicine. Dr. Boyd is a cardiovascular surgeon, and he's applying that technology to cardiovascular surgery. And he and Keith Corver and I were talking last night, and Keith made the point, he said this is really an amazing thing, because up to that point, robotic surgery was more for taking something out, removing something. Dr. Boyd has developed techniques where you can actually go in and create something and change something and get a fine medical surgical result, not just removing something. So this should be a very interesting talk. Dr. Boyd comes to us from Stanford. He's an associate clinical professor there. He did his undergraduate at Notre Dame, so he's a DOMI, and medical school at Indiana, and then residencies and fellowships at Indiana, and then some additional trainings in Good Samaritan Hospital in Cincinnati, and then at the University of Pennsylvania. I think that's where he probably met Joe Wu, and Joe Wu's the chief of cardiothoracic surgery at Stanford, and brought Jack here to carry on in that department. So, without further ado, I'd like to invite Jack to the stage and have him begin his presentation. Please welcome him.
Good morning. Thank you very much for having me. I'd specifically like to thank Dr. Dunlap and Dr. Johnson, St. Joseph's Health, and the NCMA for the opportunity to discuss robotic health, the current state of robotic health care. Most commonly, I'm asked to speak about robotically assisted coronary artery bypass grafting, which I perform as a part of a hybrid revascularization process. Because the audience is, normally I can only get other cardiac surgeons to listen to me. So since it's a broader audience, I wanted to broaden out the topic today. And there's 3 areas that I want to focus on. I'm going to give a simplified, which is basically my understanding of robotic technology as it applies to medical care. I had a nice welcome last night, and they said, well, I'm the Chuck Yeager, or the test pilot. I don't necessarily know how the fast planes or the robots are being made, but I'm integrating them into the clinical practice of medicine. So that was a very kind, from my perspective, compliment. I think it's reflective of the great community up here that I began to appreciate when I first met them last night. And so that is my role in using robotic technology today. I'm going to give a brief and certainly not complete, and it's continuing to evolve, overview of what's occurring in the field right now. So that will be the second portion. And then the third portion, I'm still going to include a little bit on how we do robotic cardiac surgery, because I think most people do enjoy watching some heart surgery, but I'll keep that short and at the end. I have no disclosures, but I would like to say that I was pretty good at math, but I'm not a mathematician, informaticist, engineer, or computer science. And the mention of the commercial entities later in the talk does not imply an endorsement, but because we wanted to do a current overview of what's out there and what's coming, some of them will need to be mentioned. And finally, I'd like to thank some of my collaborators for assistance in putting this talk together, the slides, some of the science that's done behind it. And that's David Larson, Owais Khan, and Allison Marsden. So what is the current state of robots in healthcare today? So I've got 4 things listed here. I see the first 2 is economic, the third is social, and the fourth is cultural. And I think it's important that we look at how robots impact healthcare today across those realms. So when the companies are forecasting their growth, it's X billion dollars now, and it's 3 or 5 X billion in 2025, or however they calculate that. I think we also have to look at how healthcare is really being practiced and what we see, our interactions with our own healthcare systems, and the financial situation. And I think as technology enters healthcare, it will be impacted by that. Finally, the political ramifications is more the social aspect, and it's not political, red state, blue state, or anything like that, but the people that are involved. The patients, the private practice physicians, the hospitals, and how they practice and how this technology is going to impact their current practice patterns or the delivery of healthcare. And finally, there's all this talk, there's all this money, there's all this change going on, but yet we don't have a great way to measure what this is going to do for us in the future. And I think that's a very important thing that we need to focus on. For the purpose of this talk, I've left out a lot of data slides. We're not going to talk about percentages or anything like or studies, but I wanted to give just a general overview. So, when I think about robotic technology in surgery, I think about an autonomous surgical robot. I have the robot, you put it up there and it does the surgery. Well, we're nowhere close to that yet, but in the news just this week, autonomous cars were back in the headlines for reasons that they weren't excited about, where an autonomous car was involved in an accident and it caused a human death. This is a video that started at the Safeway close to my house, an autonomous car company, and then drove through Los Altos back to the company headquarters. And you can see what the person in the car is seeing, and then on the right side, you can see what the car sees and how it identifies objects. Obviously, this isn't fast forward. But what grows in my mind from this is if the technology exists to put a car on the roads and drive it through, mostly safely, are there ways that we can do this in surgery? Okay, so I think starting with some definitions of words that frequently get used in these contexts will help increase the understanding. So machine learning is a field within computer science that gives computer systems the ability to progressively improve performance on a specific task with data without being specifically programmed to do so. And this is exhibited as artificial intelligence. And the definition that's listed, it includes intelligence in it. Normally I wouldn't use the word in the definition of intelligence demonstrated by machines, which means the ability to perceive or infer information and to retain it as knowledge to be applied towards adaptive behavior within an environment or context. So if a program, Classic thinking of a computer is you program it, it repeats the same task over and over. But how can it take in its previous experience and adjust in the future to increase precision, increase accuracy, make fewer mistakes? And this is the thought process, and the way this gets tied into action is through robotics. And that's the motors that bend elbows and twist joints and go from your fingers, and then that makes the robot do that. So the machine learning and the artificial intelligence would be the cognitive portions, so to speak, and that's translated through robotics. Last year in Nature magazine, a study out of Stanford covered the automatic classification of skin lesions. And this was done by a convolutional neural network, which I don't know a whole lot about, but we'll talk a little bit more later. And what this did is they loaded 130,000 images of classified dermatologic conditions into the program. And there were about 2,000 diseases spread among these 130,000 pictures. And then they tested the computer program against 21 dermatologists. Probably people I walk past, but we don't see a lot of dermatologists in the hospital, I don't think, so I don't know if I know any of these people or not. And they wanted to identify seborrheic dermatoses versus keratinocyte carcinomas, so very common things. And then they also wanted to see if they could distinguish, if the computer could distinguish between malignant melanomas and benign nevi. And through the study, so snap a picture and the computer tells you what it is, or the program tells you what it is, and a dermatologist sees the same picture and tells you what it is. They compared the two, and they were roughly equivalent. So, I mean, what does this mean? Can dermatologists be replaced by an app? So, I mean, it's usable on mobile devices. I think it's another tool in our armamentarium. It can broaden the scope of a primary care provider. It can augment the clinical decision-making of a dermatologist. It hasn't yet been evaluated in the real world, but it catches a lot of headlines and causes people to think and jump to conclusions. And, I mean, the hope is this really does have potential to greatly increase access to medical care for people that can't get in to see a dermatologist. I mean, there's a real benefit here. And I think it's easy to think ahead and say, what could be the impacts on this on ophthalmology, ENT, radiology, and pathology? So this is how it was explained to me how a convolutional neural network works. So the top left, we have a classic neural network where you get input. It's run through nodes. The nodes communicate by numbers. There's equations in them, and it spits out the output, which can then be interpreted into the result. These have been made more complex, and you can see the top right, where you layer more and more nodes in sequence. And then finally, a convolutional neural network is where it becomes 3D, and there's forward processing, backward processing to get to the final output. So an artificial neural network are computing systems that learn progressively to improve performance by considering examples without specific task programming. For example, you feed the computer a bunch of images of cats, it digitizes them, interprets the numbers, and you put another picture of a cat in that it had not seen before, and it recognizes it as a cat. But it doesn't know what a cat is. It doesn't know what fur is. It doesn't know whether it likes cats or likes dogs. So to go into this a little bit further, there's just available on the internet, something called ImageNet, which is a visual database used in object recognition research. People have entered 14 million hand-entered images, and one of the things was, is this guacamole or a parrot, right? You versus a computer. And so they've been doing, the images were loaded in the early 2000s. In 2010, they started a competition to identify objects. in 1,000 unambiguous cases. All right. So people are running their programs for a couple of years, and they could get 70 or 75% they could sort out into one of the 1,000 different classes that they had to choose from. And then in 2012, a team used a convolutional neural network and increased the accuracy from the 70-75% range to the 85% range. And in the past few years, it's increased to between 90 and 95%. And from a surgeon standpoint, when I work with on robotic technology, computer vision is an important thing that we need to work out. Now, this is very impressive. These pictures are cute. But there are some things that these computers can't do, because they can tell you it's a cat, but they don't know what a cat is, and they can't tell you if the cat's on the couch or on a field yet. And it's only sorting into 100 different or 1,000 different classes, whereas humans can do many more classes than that, and they can also give you context. So if we look at a scout image from a CT scan, right? The plain X-ray they take before, and all the CT scanners are digital. What does that mean? Well, really, it's digital, so it's a bunch of numbers. This is an Excel spreadsheet of that same scout film. Each number represents a different shading. And then if you put the shading on top of the numbers of the Excel spreadsheet and slowly back out, you end up seeing the scout film. Okay? So this takes, all right. So if we go back to what a neural network is, and we look now on the bottom left side, if it takes a digital image, runs it through these nodes that's really communicating by different numbers and equations, it can recognize a lesion in the liver or a skin lesion for the dermatologic process. It's very impressive and very powerful. When I wrote this next statement, I had trouble choosing the verb. None of these things should, the way I came across it first, it said none of these things will happen without individuals who understand the technological advances can bring upon us. But I think a should is a more appropriate word for how this, and I think what that calls on all of us to do is to remain involved in the development of this technology and make sure that it's implemented in the proper way, that we see the benefits that we're looking for. I also thought another very interesting thing when we think about artificial intelligence is this quote by Edsger Dijkstra, who was one of the founding fathers of computer science along with Alan Turing, who said the questions of whether machines can think is about as relevant as whether submarines can swim. At this point, I still think these are tools that we need to use and not the end in itself or a replacement of it. When we're thinking or talking about machine learning, artificial intelligence being replaced by a robot, how long is my job safe? It causes me to think about some of the dystopian novels that have been published, such as 1984 by George Orwell, Brave New World by Aldous Huxley, which was published in the 1930s, Fahrenheit 451 by Ray Bradbury, and then more recently, The Hunger Games. So I think these questions that this technology raises, people have been thinking about for a long time. There's certainly more technology now, but I think the issues have been relevant for a long time. And then also, if you hearken back to, if you read any sci-fi literature, generally as a teenager or a young adult, there were 3 laws of robots to codify or standardize how robots had to interact with humans. And I think if you read these and substitute some words, it's interesting. So the first law is a robot may not injure a human being or through an action allow a human being to come to harm. If you substitute doctor, physician, or healthcare provider for robot, it sounds a lot like the Hippocratic Oath. If you look at the second law, is that a robot must obey the orders given to it by human beings, except where each order would conflict with the final law. And not going to get into the ethics of end-of-life care, but I wanted to use this as an illustration of patient autonomy. And then the third law is that a robot must protect its own existence as long as such protection does not conflict with the first law or the second law. And I think that's what I would call upon here to all of us to say, as the physicians or medical practitioners, that after we're taking care of patients in the manner that they deem appropriate, we need to make sure that the whole profession carries on appropriately and that the technology that is developed protects us, not necessarily for selfish reasons, but so that we can continue treating patients with their autonomy. So that was a little background around quick overview of the science and my thoughts on how we should look at it moving forward. And then I want to switch forward into the top uses of robots in healthcare today. So it can be broken down into these 6 major areas, and I'm going to focus on more the computers and the mechanical technology rather than stem cells for technology in healthcare. And so telepresence, surgical assistance, which is where I spend the majority of my time, is working with robots, rehab robots, primarily for spinal cord injuries and injury rehab, sanitation and disinfection, going around and cleaning the hospital, as well as prescription dispensing systems and complex healthcare systems, getting the drugs to the right place, having them accounted for, having them available to the nurses. That's a lot of work. It can be, some of it can be, lots of it can be automated, if not all. And finally, medical transportation. There's robots that can carry things around the hospital the way an autonomous car can carry someone through the roads. I'm going to give a couple examples of companies in each of these categories. And again, this is not an endorsement. These are just, this is what's out there. This is not all inclusive, and it changes at a very rapid pace. So there's a company out of Santa Barbara called InTouch Health that basically is a network and has cloud connectivity with security. And it also provides workflow tools and medical devices with applications on them to facilitate healthcare. So what it provides is the physician's entry into the computer system, protects the information, it's contained in the cloud, and then the patient can have access to it on the other end. And you can show up with your own iPad or device, and they can load the software on there, or they can supply the whole device for you. And this is a way that it's just a product that's organized how we want to use the internet and our computers to hear from our patients and to get them information as well. So the top right is basically your phone or an iPad that you can communicate with the patient with. And then on the bottom left is a station that has a monitor on it and some cameras, and it can be wheeled into the patient room, and you can be on the screen and they're on your screen, and so you can interact with them there as well. Another company along these lines is Vigo, located in Massachusetts, and it's basically enables a person to replicate at both a complex and a simple level. It's a remote control car with an iPad at the top of it, right? So you can, the person who it replicates sits down at their computer, can drive this little robot into a room. Their face pops up on the top of it. And they can interact with patients that way. They've all created the system that it protects all this information, and so there can be distant healthcare visits. This can also be used, kids that can't go to school can get one of these, and they put it in school, and the kid at home can drive it around to class, can participate in class, can go to lunch or out to recess. And then you see how possibly you'll see these robots working later when we all gather around the water cooler to talk about the NCAA tournament or whatever's going on at work. Where I have the most experience and interaction is with the surgical healthcare companies. These are 6 or 7, I guess, of the ones that are either utilized much more because they exist or talked about more in the press currently. So Intuitive Surgical, and I think you were able to play with a Da Vinci robot last year. The Da Vinci surgical system came out about 15 years ago and has been used for more than 3 million surgical procedures. And it has a magnified 3D high-definition vision system and tiny wristed instruments, and this company is located in Sunnyvale, California. So in the top right, you can see the surgical docking station with the arms that go into the patient. In the bottom left is the console that the surgeon sits at to drive the arms of the robot. And the bottom right is a cart that the rest of the room can look at with the information what's going on inside the patient during surgery. TransEnterix is another company. This one's out of, it's a European company, but the US headquarters is in North Carolina. And it is, I would say, has similarities to Intuitive's Da Vinci. They stress the comfortable ergonomics that you can see in the bottom left, the surgeon sitting in the chair rather than with his head docked at the console. It builds on laparoscopic techniques that most surgeons have at least a portion of in their practice. There's haptic force feedback. One of the shortcomings of or drawbacks of the Da Vinci is that you can't feel what you're doing with it. There's no tactile sense. It's just visual. And this technology will have some of that haptic feedback. And then you wear a special set of glasses that if you move your head forward, it zooms in. If you move your head back, you zoom out. Along those lines, and other technology not for this product that can be involved in, separate sensors, either ultrasound or infrared, other ways of computers seeing things can be placed in these systems to aid in visualization during procedures. Another company is Robotics out of Massachusetts. And I actually think they have the name switch. I think this should be TransEnterix because it goes in the mouth and in the rectum, but wasn't involved in any of that. Basically, it's a very fancy endoscope, right? It's computer driven. Nobody pushes on the scope to get it to go forward. It's driven with a joystick. And when it gets there, there are instruments that can go in tubes along the side of it that also can move with the tube to resect polyps in the colon or work on the vocal cords. And so this does have FDA clearance, and it can be used in colorectal procedures. Current robotic surgical system is quite large and bulky. Out of the United Kingdom, Cambridge Medical Robotics is developing a robot called Versius. And the technology in it is about the same as the technology in your cell phone. And rather than having the big station that rolls up, there's going to be 3 separate arms that you can just attach onto the side of any surgical bed. And then be able to do very similar things to the Intuitive's Da Vinci. It also is guided by a 3D screen. In addition, there's Titan Medical's Sport surgical system. Okay? So instead of having 3 or 4 arms that go into the patient, the Sport is single port that goes in. I think it's a 10 millimeter trocar, and then the camera comes out and is movable, as well as the instrument arms. And so you're trading the 3 arms for 1, but then the same basic principles for how to utilize it. Someone sitting down at a machine and driving it. But what's around the corner and who's getting involved in this? The startups, across Silicon Valley, Massachusetts, Switzerland, Japan, but there's big players that are getting involved in the field, significantly involved in the field. One of them is Verb Surgical, which is a collaboration between Johnson & Johnson and Google or Alphabet. No one has access to what it looks like or exactly what it can do. It's still a prototype. But their stated goal is that they want to bring more surgical robots into healthcare within 2 years from now. So I think as we see this increased competition, there will be some decrease in price. I mean, a current robotic system costs about $2 million with a couple $100,000 per year maintenance fee. So there's definitely cost savings available moving forward. Oris Robotics, also located locally in Redwood City. So this was founded by one of the founders of Intuitive. It's a system of flexible arm and cameras, and so I'd say somewhat like the Med Robotics that we talked about earlier. It enters the body through the mouth, and it's being designed to remove lung tumors. So we'll talk about this as incisionless surgery, right? If you enter a natural orifice of the body and they're still able to remove something. And if you look at this picture on the right, it looks like your Xbox or PlayStation joystick to drive it. And I think that, people always ask me if I played a lot of video games growing up. I didn't, but I think you can see that some of those skills really are going to be applicable moving forward. Another big player entering the field is Medtronic, and they licensed technology from the German Space Agency, and they're also working on a robot that gives not only sight but touch or the haptic feedback, what's been missing from robotic surgery to date. And this will start, surgeries are planned for August or September of this year in India. So moving on from surgical assistance to rehab options, there's exoskeleton companies like Exobionics from Germany, Cyberdyne from Japan, Hokoma from Switzerland. And what they do is they have these devices, artificial legs that can be put on. Some of them have to be controlled by your hands that get your legs to walk, so someone with a lower spinal cord injury. There's videos online of people walking with these. And so originally they were developed to help clean up from Fukushima nuclear disaster. They put someone in a suit, they need to be able to move around, and they need to be protected from the radiation. And then one of the side benefits of this was they said, well, if we just take the legs and we don't need to protect them from radiation, someone can walk. It supports its own weight through the struts that it has. And these exist and are at tech shows currently and are being used in rehab facilities. They also have devices that you can hook arms up to that can just run both arms through range of motion exercises for rehabbing. So I think there's a lot of opportunities here for healing, for helping people rehab and recover. If we look at robots and how they're entered into your pharmacy and medical management in the hospital, there's 3 companies that could spring to mind. Atheon out of Pittsburgh, Omnicell, which is formerly Ascent, located in Mountain View, and Innovation Associates in New York. And what these are, they're basically workflow management companies. They can count the pills and make sure they get to the right place. The robots can dispense the medicines, and these are scalable from small pharmacies to 1,000-bed hospitals. And in the top right corner here is a robot called Tug. So it can get loaded up with the medicines and take it out to the individual floor and deliver medicines to the Pyxis or wherever the medicines are stored on the floor. You can take off the drug dispensing device and hook up the bucket that carries the towels and sheets and other supplies around the hospital. So this kind of covers multiple aspects. This one company is both in pharmacy and then just in some of the day-to-day work of the hospital. Can also look at sanitation and disinfection. After all of my operations, if the patient had a history of VRE or MRSA, they bring in this robot on the right, which turns on UV light. There's been many studies that say, or that show that it more effectively cleans a room than any person can or group of people can scrubbing. And this just reminds me of the Roomba, which I still want to get, but haven't, which is the little vacuum cleaner that maps your house out and rolls around on the floor and cleans up for you. Here they're very helpful if you have dogs that shed. And it will learn the map of your house, the newer generations, so that it doesn't bump into the fixed things. Okay. So the last category is companions, and 3 companies here. Luvosa out of Maryland, Honda Robotics, which is Honda, but they have a Silicon Valley robotics lab, and AIST, which is the robot research program out of Japan. So the top right is the Honda robot, which is basically a souped up Siri on wheels. All right, yeah. So it will roll around, interact with people. The skin that they put on it is supposed to be very comfortable, so kids want to come up and touch it. I mean, it could be used in malls to direct people. It could be used in hospitals to direct people. But you know, it's funny, it's cool. It has a lot of future uses that haven't been integrated at this time, but there's certainly, I think it's pretty easy to see where this is going. In the bottom left is the Luvosa companies. It's called SAM, and what this does is it's like the Vigo that we talked about earlier. Right? It's an iPad on top of wheels that's remote controlled, and someone in an office can run around rehab facilities and check in on the patients regularly. Right? Ask them how they're doing, and then notify the local staff if if this needs in-person care at this time. And bottom right picture is Paro. It's made it into lots of popular TV shows, and it can be seen on that. It's the little seal here. It's a seal robot. And this is not Sister Jean from the Loyola basketball team. But this can interact, the robot interacts with people, and they can demonstrate how some benefits that there are in interaction with pets that people have. Part of this could be replaced by a robot. They chose a seal because people had expectations of what a dog or a cat would behave like, or whether they liked them or not. Most people think seals are cute, but don't really know how they behave, so it allowed them a lot more leeway with the interactions that they could create with it. Okay, so I think that's just a quick overview of some of the major areas that we see robot penetration into healthcare. Those are some of the more popular companies. This is not meant to be any endorsement, but just so you hear it one time, so if you hear it again, it'll start to register. And now I want to transition into actually my practice and how I currently use a robot. As Dr. Dunlap said, I'm a cardiac surgeon, and the title of mine was a simple country heart doctor, which before I worked at Stanford people were more accepting of it, from Indiana, and did heart surgery there. And I mean, heart surgeons have a pretty high opinion of themselves, but so in the Midwest, we try to, we give some importance to humility as well, so we're kind of both sides of the coin. We think real high of ourselves, but we try to pretend we're humble, or try to be humble as well. So just doing a cabbage surgery. So the way I use robots, and not just in surgery, is work with some of our engineers for CFD. This is a picture of one patient who needed bypass surgery with images from a CT scan. And what we did was we said, well, what if we did the surgery different, right? So here, one of them is with the 2 IMAs and a vein graft, and do we wire the vein graft or sequence the vein graft? And then so the computer, we can take apart the surgery, move the grafts around, and run simulations and say, if we did it this way and the flow is different here or for a different lesion, which way will the computer predict that this graft will remain patent for longer? So this project took about 2 years for one patient that had already had surgery, and it's pretty hard to get CT scans on everybody that needs bypass surgery. So currently we're working on a program that will automatically, if you feed it the angiogram, it will do a 3D reconstruction. You don't need to teach it anything about it. You just run the cine through. It will draw out the center line. It will measure how wide it is. It will find out where the narrowings are. It's able to correlate the heart cycle from 2 different images because you get orthogonal images, and it's going to drop them on top of each other. But when they're shooting the cine, when the heartbeat doesn't line up, it automatically does that. And that way we can plan for improving bypass surgery, seeing what different options we could place: arterial grafts, venous grafts, many separate grafts, sequencing the grafts, wiring the graft off. So it's going to be a tremendous tool that will allow us to improve bypass surgery. So specifically for robotic cardiac surgery, okay, this is the surgery portion. So I do a robotically assisted, minimally invasive Lima to LAD bypass. So what that means is I take down the mammary with the robot, move the robot away, open up one of the small incisions just a little bit, and do a hand-sewn off-pump, so beating heart bypass. And then either the day before or the day after, or sometimes the same day, that patient will get stents to the non-LAD territories. So we work as a team together to plan this out, and my interventional cardiology colleagues will stent the right and the circumflex around that. So for this patient, the patient's head is kind of towards the bottom left of the screen, and the legs are going out the top right. So you can see the 3 ports in the left chest that are in approximately the 2nd, 4th, and 6th intercostal spaces. Okay. After we place the ports in, we bring the robot up and attach it. So we're now looking at the patient from the patient's left side. The head is to the right side of the screen, the feet are to the left side of the screen. The arm that you can see on the far left there's a forceps in there, a bipolar forceps. So I have an energy source on it. The middle port is a camera, right? And actually it's 2 cameras so that I get 3D vision when I sit down at the console. And on the right side is a Bovie cautery. So if we were doing this open, I'd have pickups or forceps in my right hand and a Bovie cautery in my left hand, and Bovie cautery in my right hand, and I'd be looking in the middle and work like that, and that's how the robot's set up. So once I put the robot into the patient, I go over and sit down at the console. This is what allows me to see and to drive those arms. They turn off the lights in the room because it makes for a better picture, but it really has no impact whatsoever. And we get to work. So this is inside the patient's left chest. The patient's head is to the right. The feet are to the left. You can see the pericardium and the heart beating underneath there. So you're kind of from down looking up to the anterior chest wall. And this is the left internal mammary artery. That I'm dividing the fascia over the top of it with the Bovie cautery or spatula in my right hand and a pair of forceps in my left hand. Okay. Takes about an hour, so I'll fast forward through the videos for you. This is after we've done a little more work. Free up the far side of it first, and then come back here, and you can see it better defined. You can see the pulsations within the artery. In this video, the patient is oriented in the same direction. This is what I see when I'm sitting at the console. And this is similar to what we do in open surgery, but not exactly. This is what the rest of the team is seeing while I'm taking down the mammary. They have a screen to look, and sometimes the robotic arms need an adjustment, or we switch arms, switch the instrument in each arm, and this can be done there. Okay. This is a half hour, 45 minutes later. We can see that the whole artery has been freed from the chest wall. Scrub back in, take the robot away from the patient, and extend one of the incisions. So again, this is in the patient's left chest. And a special stabilizing device is going through the upper epigastrium there to hold the heart still while we do the surgery. So patient's head here is at the bottom of the screen and feet are at the top of the screen. And if we zoom in on the incision, it's about a 3-inch incision. And you can see the heart on the inside there, and there's a device that's a stabilizer to hold the aspect of the heart still that we'll be operating on. Okay. Just basically same picture here to see where you can see the heart and the stabilizer. And then, so it's, oops, sorry. There we go. Okay. These are, so now through the incision, we're opening the coronary artery here. This is basically the equipment that all cardiac surgeons currently use after the robot, so the regular equipment. And this is a completion of the anastomosis. So you're looking in the left chest here. The tube running off to the right is the internal mammary artery, anastomose to the LAD. So a single vessel off pump, robotically assisted bypass surgery. The reason that I'm interested in this is because of the societal burden of coronary disease and the benefits of revascularization and the ability to get the best of both worlds, of both the benefits of PCI, not having to have real open heart surgery to revascularize things, but still hanging on to the best part of cardiac surgery, the left internal mammary artery to LAD bypass. That's been the portion of revascularization that's consistently been shown to improve prognosis. So we can package something where you still get the best parts of surgery. You don't quite have open heart surgery. We're getting into a little bit of semantics there. A shorter hospital stay, but being completely revascularized by having stents placed in the non-LAD vessels. This is what the incision looks like at the end of surgery. And so I guess in summary, robots are being used all across healthcare. Surgery catches a lot of attention, I think, and that's where I'm involved. So I think the next steps are how we integrate the machine learning and artificial intelligence as tools that we as individuals can use to improve care. And I think we need to, or at least I think about it, that it's not just surgery, but it's across the entire spectrum of the delivery of healthcare. Thank you.
We have time for questions for Dr. Boyd.
When do you think the anastomosis part will be also over time?
Still, I think years. So the technologies, they have anastomotic devices, mechanical devices that you load the two vessels on and then fire it, and it staples the anastomosis all at once. But the practicality of that is limited. It's technically very difficult. It doesn't work well with the robot now, but I think future iterations, I'd say the technology exists currently. It's not practical. It's not usable. So I work at Stanford. I have much of my time protected to do these surgeries, where most people that do heart surgery, and most of heart surgery is done at places not like Stanford, so it needs to be something that can be done everywhere, and that doesn't exist yet.
How do these surgeries work when it's a female patient? Because it looked like it was over the breast area where we're doing surgery.
Yep. So for a woman, usually with the inframammary crease, and then we have to kind of mobilize the breast superiorly is one option. And then the other is, in some women, depending on the size of the breast, we can pull the breast way down, and they'll have a small incision at the upper aspect of their breast.
I heard about 50 people's antennas go up when you started talking about the application for identifying dermatologic lesions. Is that available now?
No. So the app exists. You can't go to the store and download it onto your phone. But I haven't spoken to the group specifically, but I think that my guess is that's very high on their list of things that they'd like to do. But it hasn't been validated clinically yet. It was just a pure research study done with pictures and their group of dermatologists.
Chest tubes, and when does the patient end up going home?
So yes, I leave a chest tube in to monitor for bleeding and to evacuate any air in the chest. It usually comes out either post-op day 1 or post-op day 2. And the average length of stay for the robot bypass surgeries are between 3 and 4 days. People have been ready to go home at day 2. I'm not ready to send them home yet because of post-operative AFib, and I guess I'm still not as forward-thinking or aggressive as I like to think I am.
Is there any difference in insurance coverage for different procedures with and without robotics?
So a very important point, no. Yes.
Last year, we had a urologist talking about robotic urologic surgery, and it was brought up that most of the urology residents are learning how to do robotic prostatectomies, but not how to do non-robotic prostatectomies anymore. And if that's the case, every little hospital in the middle of nowhere can't afford a robot. What's going to happen to the distribution of urologists in the country if that's the case? The same question could be asked of thoracic surgeons.
Right. So I think that's where we have the political and social ramifications of robotic technology entering the medical field. I don't know the answer to that question. I think one way to look at it is with new companies entering the market, it's possible that the cost of these devices will come down. Then you also, at least currently where they're surgeon driven, you need someone trained on how to use it. And I went through general surgery training kind of when laparoscopic cholecystectomies, they'd been done but weren't necessarily routine when I started. But by the time I finished, we didn't do open gallbladder surgery anymore. So from the first time it was presented, they ran the guy out of the room who said, I did this with a camera, to 8 years later, 95% of gallbladders were taken out that way. And so the surgeons were learning at the same time, or the residents were learning a little bit behind them. And so taking out an open cholecystectomy, is that still a skill that's necessary? I don't know the answer to that question.
Sometimes.
Sometimes, yes. But then I think, good surgeons were able to learn so that almost all gallbladders are taken out laparoscopically, and I don't know the exact numbers, but the vast majority of prostates are taken out robotically. What are the one-offs, or 5 or 10% of the time, if it needs to be done a different way, does that need to go somewhere else? That would be one possible solution. But I do think, people want their health care close to home. If the cost of the device comes down, more hospitals will have it, or there will be regionalization and specialization for the procedures would be another solution for that. And I think that, at least when you talk to, or when I hear from hospitals or companies involved, that seems to be the avenue that they support.